Well, welcome Doctors Karyn, Eilber, Victoria Scott, and Jennifer Anger. I'm so happy to have you guys with us today to discuss everything pelvic health. We're going to be focusing on recurrent UTIs and interstitial cystitis, bladder pain syndrome. I'd just like to quickly introduce everyone who's here today. So to start with, Dr. Karyn Eilber is a professor of urology and program director for the Female Pelvic Medicine and Reconstructive Surgery Fellowship Training Program at Cedars-Sinai Medical Center. Her research is focused on urogynecology and female sexual dysfunction. Dr. Victoria Scott served as Director of Education for the Cedars-Sinai Female Pelvic Medicine and Reconstructive Surgery Fellowship Training Program as well. She is passionate about educating her fellow healthcare professionals about the treatment of female pelvic floor disorders. And Dr. Jennifer Anger is the professor of urology and vice chair of research at the University of California in San Diego. Currently, her research in health disparities identifies barriers to women's access to healthcare. So welcome. Thank you guys for being with us today. And yeah, so I'd love to dive in just based on your research, Dr. Anger, if you can just sort of let us know if anything is being done to address these barriers.
There are major hurdles that we still need to overcome with regard to women's health. And it goes down to young teenage girls. Girls have questions about sex. No one talks about things. Older women don't talk about incontinence. We are embarrassed of pelvic floor disorders. And even recently, some of the research that we've done has focused on just getting the doctors to ask the patients about incontinence. And it's not that doctors are afraid to bring it up. I really think it comes, maybe they're less comfortable, but patients don't bring it up, even when it's bothersome to the patients. So one thing that we're doing is identifying patients that screen positive for bothersome incontinence, and then alerting the providers in the medical record, your patient screened positive for incontinence, please address it at your visit today. And that seems to make a big difference. But because women tend to have so much shame around incontinence, doctors don't necessarily know to bring it up. It tends to go unaddressed. And that's not only incontinence, sexual dysfunction, urinary tract infections. So many of these conditions are, kind of classically embarrassing. And they shouldn't be.
It's so interesting because people go into the doctor's office and they, sometimes feel like they're going to be the first people to say that they have, incontinence or pain with sex. And doctors have heard it all. So it's just, we have to sort of get past that and, reduce that stigma really so that people don't feel uncomfortable anymore addressing these very prevalent issues.
It's so true. Urogynecologists, for example, like people who specialize in women's pelvic health, we tend to be comfortable with it, but it's often a problem getting the patient to the right provider. And some of our interventions have really focused on primary care doctors, improving their sort of initial management of incontinence, screening of incontinence, so that the doctors, know where the patients can get the help they need if they can't give it to them themselves.
And the stat on incontinence, isn't it? It's so common. So I think it's something like
absolutely up to 50% as women get older. It's definitely rises in prevalence. So it's very high.
Yeah.
But I think it's more than just being comfortable discussing it. I also think we tend not to discuss things that we're not trained well on. So a lot of, whether it's gynecology residency, urology residency, we don't always get training on that. Things that are obviously, I don't want to say more important, but like cancer treatment, those things tend to be emphasized in training programs. But also one of our research projects, we looked at, there was literally a questionnaire sent to practitioners in our specialty like 20 years ago as to like how often they address sexual health for women and if they felt comfortable about it. We used the same questionnaire 20 years later because we just happened to cross that paper and we knew the author of that original paper. We gave the same questionnaire to, again, our same specialists, and it was almost the same responses. So in 20 years, the comfort level of practitioners in addressing sexual health and knowing how to treat sexual problems has not changed. So it's a little disappointing and depressing in that. Having said that, you have to learn so much in a finite number of years. So if you don't have interest in that, it'd be really hard to, get any type of comfortable level so that you can address those issues with your patients later.
And I feel like that's also the same with conditions like IC and recurrent UTIs. I mean, doctors, I've been told the amount of time that's spent, educating you guys about these conditions is so minimal.
Mhm.
And it's just, I mean, it's shameful, really, because it's such a huge number of people who struggle with these conditions. So it's just, I'm really hoping we're going to make some strides in the next, 5 to 10 years. And people are going to actually take an interest in studying these conditions, these chronic pelvic pain conditions. And it's just, the number of doctors who actually specialize in IC is so minimal. I mean, it's just, nobody wants to touch it.
I think
So,
we really need more research in the laboratory, the clinical trials, developing new drugs. But another area that we're really interested in on a smaller scale is more of the qualitative studies, like looking at actual patient perspectives too. So we have done our research group has done some studies with focus groups, looking, for example, at patient perspectives on our current management options and education we provide for recurrent urinary tract infections. And one interesting outcome there was, although many providers think, okay, I've got my patient with lots of UTIs, they call, okay, I just need to send them antibiotics, get them quick treatment. While that's a common perception, a lot of these women we found in our focus groups were saying, well, actually, we are scared of antibiotics. We're now understanding more the dangerous side effects of taking so many antibiotics. And so they were really educated and frustrated with that practice, where, again, it showed that disparity between what doctors think they're providing help, when in reality, we have to help check their urine each time and be a little bit more in depth with our guidance and focus more on prevention too, instead of just throwing antibiotics at them. So that's another interesting example of how we really need to continue to look at patients' perspectives and what they need and want from us too.
is there any have you guys heard of anything about the MV140 coming to the US or Canada? Because I know that has been sort of a subject of sublingual, they don't want to touch it for some reason. It's a sublingual vaccine.
That's the vaccine, right? Yeah.
Yes, and for some reason, and it's in Europe, and many people have had a lot of success with it, but for some reason, Canada and the US do not want to touch it.
I just think that's typical. I think just regulatory. That's why many, drug developers, from what I understand, will start in, Europe, other places first. I just think it's a little more difficult. It's definitely like on the radar, but yeah, I can't really offer it to anybody because it's just not available yet.
Do you have a lot of patients asking about it or for it? Or
I've had a few. I mean, honestly, probably less than a handful. But there was, I believe there was a study in Victoria, and Jen, you can correct me if I'm wrong, several years ago, there was an intravesical treatment, I thought, for something. But yeah, other than that, I haven't had a lot of people actually ask about it yet.
The author of a recent paper, who kind of summarized the data is our colleague, Dr. Curtis Nickel. So and he's also an IC expert. So I think it definitely holds promise. But a lot of before something can actually be incorporated into like a guideline where we make recommendations, we need some real strong evidence from what we call randomized controlled trials. So hopefully that will, it would be amazing to have a UTI vaccine. But, it's interesting. Most of our vaccines in general address viruses, not bacteria. So I think that's sort of where some of the complicating factors are.
I think it's also that it's a sublingual, and they somehow are not, comfortable with a sublingual vaccine versus an injectable. Yeah, so that seems to be the main issue, because both the FDA and Health Canada are sort of sitting on,
on the formulation.
But wasn't the polio vaccine oral?
They have both. Yeah.
So I mean that wouldn't be like a totally new thing. I mean, there's precedence for, but who knows?
Yeah. Because you would think people want sublingual over a needle. I mean, I would, right?
Why not?
Exactly.
People who are scared of needles are like, sublingual,
Exactly.
sign me up. Yeah, but I guess
But I think it's a shame, though, like to Victoria's point or Dr. Scott's point earlier, that interstitial cystitis or IC, it's this chronic condition, I think partly because every time a woman has symptoms, we just always say it must be a UTI. Even though you haven't gotten better with 5 courses of antibiotics, it must still be UTI. And I do think there are probably a fair number of women that we have created their disease simply from overtreatment. One of the research things we worked on a while back was looking at the microbiome of people who have IC. And although the urine is a little more on the sterile, like with traditional cultures, we don't always grow something. When you look at a molecular level, there is definitely a diversity of different organisms we just don't pick up with traditional culture. And women with IC have less diversity, meaning we probably killed a lot of like their microbiome participants, if you will. So it is I always wonder like, how much is IC like its own disease versus we actually cause this in a lot of people?
Mm-hmm. Well, they used to call it back in the day the hysterical bladder disease.
Well, that's why you have hysterectomy, because it removes your hysteria.
So
is that I never
as opposed to uterusectomy, because it was believed that your uterus was the cause of your hysteria. So if you remove the uterus, you remove the hysteria.
And they haven't changed that name yet. Interesting.
So would you like to talk about health disparities in relation to gender?
I was just saying, wow, that's unbelievable. I never even thought. It's interesting. I never even thought about where it got its name.
I think everyone kind of assumes, because medical terms are typically like Latin or something. I think everyone just kind of assumes like hyster is for uterus, but it's not.
Yeah, hysteria. Wow.
Yeah.
Wow. So what about management options for patients with IC and recurrent UTIs? What do you usually recommend to your patients?
We have women who are treated with antibiotics, and then maybe several times, and then finally and often they're just treated over the phone. They often go to the doc in the box that we see now. These telemedicine doctors, they'll get antibiotics, and then it takes several times to where they will finally give a sample for culture, and it's determined, wait, you don't actually have a UTI. So we often see a delay in diagnosis of IC because they're treated or mistreated with UTIs. But once we see those women with once it's determined that they don't have a UTI, that they have IC, that they may be experiencing a flare, we will still have them drop off a sample, so we make sure, because women with IC can also get UTIs. Mm-hmm. But then we have to make sure that it's not a UTI, and then we start treating the actual symptom flare.
Mm-hmm. It happened to me. I mean, GP tried 3 different antibiotics and then finally went for a cystoscopy under hydrodistension to diagnose. But yeah, it was quite a frustrating process and scary too, right? Because you think, oh, this antibiotic is not helping me. Like, what is going on here? And at that point, you don't really know much about interstitial cystitis, so you just assume you're just resistant to antibiotics. And it's quite a, and it can last quite a while too for some, until they actually find out, what's going on. And I think, the general practitioner will often, for them, it's prescribe antibiotics. But even so, like sometimes when you don't see, this is the part I don't really understand sometimes, is if they're not seeing bacteria in the urine, why are they giving you antibiotics?
That's what I'm saying. That's what I was saying. I think that it's the assumption that every time a woman has symptoms, it must be UTI. So I think it's also important just to point out for anyone who's listening that if you have recurrent UTI and you only have symptoms when you have the UTIs, you probably don't also have interstitial cystitis, because by definition, interstitial cystitis has no other identifiable cause of the symptoms. So it can be really difficult to diagnose someone. There are definitely people who have recurrent UTI and interstitial cystitis, but it's really important to try to determine, are you having those symptoms when for sure you have no infection? And it's really tough for these women who get a flare, because sometimes it is a UTI that's causing their flare. So it can become really confusing sometimes. But yes, Marty, to your point, we don't get it either. It's like, let me get this straight. You had 5 courses of antibiotics. Your urine doesn't show anything. It never helped. So maybe it's not a UTI.
And the data show that women struggle with that sort of battle for like 4 to 5 years before getting an IC diagnosis. I mean, it's significant across the board.
That's scary.
Yeah,
it's a very long
But
time.
really, an important education point for patients in this setting, I think, is, what are urine tests and what are we looking at? Because there's a lot of confusion. Well, I went to urgent care. They did a quick test. They told me I had a UTI. So making sure everyone understands. So we have our urine dipstick. So this is the quick test. It's not the most accurate we can do and give you quick results. We're looking for some inflammatory markers, and one marker that's a little bit more suggestive of bacteria, particularly E. coli, but we really can't say for certain, is there a UTI or not? So it's important for patients to understand that dipstick test, we don't know for sure, is there bacterial growth, what type of bacteria, and what antibiotics can be used to treat it. So if you go to urgent care, make sure you always say, please send the urinalysis and the culture too, and then follow up on those, because you don't always get that follow-up phone call, oh, there wasn't actually bacteria. The urinalysis is a little bit better, so that's where we're doing like the microscopic evaluation to look specifically for white blood cells, red blood cells. We're a little more accurate, but the culture is the test that really takes a couple days to tell us bacterial identification and then antibiotic susceptibilities too.
Mm-hmm.
And one thing,
no, go ahead.
Just going to add, one thing that we do in a urology or urogynecology office is what's called a standing order. So patients have the order. So the minute they get symptoms, they go right to the lab. They don't have to make an appointment. And then when we get the results and can treat them early. So I think that's something patients can actually ask for, that to be able to get helps more quickly when they have these events.
Mm-hmm. What about embedded infections? What are your thoughts? Because there are a lot of IC patients, and I know this is a bit of a controversial one. And you don't have to. We can just move on if you don't want to touch on this, but it is brought up a lot, and there are people who are very, adamant on saying, I have an embedded infection, and they go on these antibiotics, and we have very few doctors who will treat with long-term antibiotics. What are your thoughts on going that route? And do you believe in embedded infection? Are you comfortable discussing it? I'll let you answer that.
Part of it is terminology. There are definitely deeper tissue infections and ones that are superficial, right? So like for instance, certain antibiotics you cannot use for a kidney infection because they can't penetrate the tissue deep enough. So I think that someone can certainly have a bladder infection that maybe is deeper in the tissue as opposed to just a little more superficial, if you will. Mm-hmm. Having said that, they should consistently feel better with antibiotics. So if someone says, yeah, I'm on antibiotics, it took me 3 weeks to feel better, I'm not really sure that was really the antibiotic, or you just felt better over time, because IC does tend to wax and wane. I think the other thing is, if a woman has, or I guess a man who has IC, has a hypertension, we often will biopsy. And if the biopsy, which a lot of the times is totally normal, you really cannot have an embedded infection if there's no organisms or cells that indicate infection. So look, I've been in practice over 20 years, so like you never say never anymore, but things do have to make sense. And it just, to me, if you're being treated for a presumed condition and you don't get better, it's hard to convince me that that is what's going on.
Mm-hmm.
It's very popular in London, the concept of embedded infection. The problem with it is it leads to what in with regard to recurrent urinary tract infections, when we looked at our guidelines, we're really focused on avoiding what we call overuse of antibiotics. So the risk of that concept of embedded infection is that it's going to lead to women taking too many antibiotics. Now, if someone says, I want preventive, like a low dose daily antibiotic, like I definitely will work with that with the patient to give that, but we don't want to give unsafe doses of antibiotics because of this sort of theory that hasn't totally been proven.
Yeah.
Yeah, I think there's definitely animal data with respect to, you know, can particularly E. coli develop these like intracellular bacterial communities and enter these quiescent states. But I would say in the human, you know, studies, we just really don't have the evidence in support of it. But again, like Dr. Eilber said, you know, unfortunately with interstitial cystitis, we don't know. It's probably a spectrum. Probably some people fall more on the infectious etiology spectrum, but unfortunately, we just still don't know.
Right. What do people do if they've been diagnosed with recurrent UTIs but think they actually have IC?
I'm pretty aggressive about UTI prevention, right? Because if someone can go a good 3-6 months without a UTI and has no other bladder symptoms, then they likely don't have separate IC. But again, sometimes it's really tough because if you have the bad luck of getting UTIs, you take your antibiotics, you don't quite get better, you're like, see, I'm having a flare because maybe your UTI flared you. But ideally in those patients, what you really want to do is be very aggressive with prevention and get them free of UTIs. And then, you know, again, if they're having bladder symptoms and their urine tests don't show infection, then, you know, they probably do have IC separately. And in addition to UTI prevention, you treat them symptomatically for their IC as well.
It's so true because like UTIs, if someone has IC, a UTI will make it worse or exacerbate symptoms. So I totally agree with Dr. Eilber. Like those patients, we prevent infections as much as possible. Then we're actually able to see what is an IC flare versus a UTI.
Another tricky thing about those patients is that because of the underlying likely IC, they may be triggered and have more of a UTI reaction with a much smaller amount of bacteria too that we may not catch on a culture. And so that's another reason why the prevention is so important. For IC patients in particular, we tend to recommend avoiding cranberry juice, even the supplements, because that can be more irritating. So focusing more on D-mannose, probiotics, and then hydration are kind of where we lean more towards. It can be safer for them.
A difficult scenario. Oh, sorry, I was going to say a difficult scenario. These sexually active women, right, who get UTIs with sexual activity, and so you try to give them some type of prophylaxis at the time of sexual activity, but then someone with IC, it's a sexual activity that triggers a flare. So it's sometimes it can be really, really difficult to know. And I think one of the best things that Dr. Anger said is we really do try to work with the patients. And as much as we try to use the science and the data, like a woman knows her own body. So you also have to listen, you know, to her, and you're like, listen, I know it's a UTI or I know it's not. You can't just blow that off. You really have to listen, you know, to the patient as well.
Absolutely. Everyone's very different. Every IC case presents differently. You know, I mean, I know a ton of people who struggle with the condition and everyone's got it. I mean, as Dr. Nickel, he has sort of placed people in phenotype. Are you guys using the phenotypes, like placing people in those phenotypes and then treating them based on which phenotype they fall under?
We definitely try to do that because you have patients with, let's say, a Hunter's ulcer who is going to do better when you focus like a cystoscopic treatment of the ulcer. And then patients that have more, systemic symptoms, what we call, outside of the pelvis, we will be more likely to use something like, for example, amitriptyline or Elavil to help with sort of chronic pain outside the bladder. So we definitely, I think that's a huge contribution of the MAP network is that work on phenotyping, that not every IC patient should be treated the same.
Yeah, then some fit into, I mean, it's sort of an umbrella, then people often fall into different they'll fall into 2 phenotypes or 3 phenotypes. So, but I think it really helps, because it's sort of like the spectrum is just so wide with IC.
Mhm.
I mean, with me, I have no pain, but I have urgency, frequency, nocturia, dyspareunia. So yeah, so it really, depends on the person. Then I'll talk to someone else who has it and they struggle with chronic pain every day, chronic pelvic pain. So it's just like you said, every patient is different. But it is great that there are those phenotypes now. I think that does help for sure. So what about diet? How do you guys feel about diet for, the diet modifications, the IC diet? What's your take on that?
If someone hasn't noticed any dietary triggers, it's pretty unusual. Like you often kind of wonder, maybe it's something other than interstitial cystitis. I would say people not having dietary triggers in IC are probably more the exception than the rule.
Yeah.
And we usually see people, unfortunately, who have had their symptoms for many years already, and they can already come in and tell you, this is what triggers me. I have to avoid this. So it's pretty unusual, I think, to not have dietary triggers. I mean, I definitely have patients who don't notice it as much, but those are, I feel like, the ones who have milder IC also.
Yeah, and that study that was from Moldwin and Shorter was from New York originally, that had like 90% of women had a dietary sensitivity. And we actually gave the same questionnaires across the veteran system, which includes women and men in like a 50-50 ratio, but also, diverse populations, different racial makeup. And the dietary sensitivity was very high, maybe not 90%, but in like the 70s, 80s%. So it shows that dietary sensitivity is really universal. It wasn't just sort of this one area of patient, of New York that were in that population. So it seems very real. And like Dr. Eilber said, like I almost use it as, even though it's not formal diagnostic criteria, in my own sort of, when I'm thinking about diagnosing a patient with IC, that's one of the things that I think of is consistent with an IC picture.
And for you all, how do you diagnose it usually? Do you do cystoscopy? Do you do based on, criteria that they meet? Like, how would you diagnose a patient with IC?
Dr. Scott, you want to start?
We've talked about this before. So I know, like, for example, Dr. Eilber or Dr. Anger has like an IC clinic. So she's seeing patients who've already had the diagnosis or, seeking other opinions. So she said that she does tend to perform the cystoscopy kind of right off the bat, just to especially look for those Hunter's ulcers. For me, my practice is a little bit more community oriented. So I'm seeing a broader spectrum of patients. And so I'll always have that discussion so that I can identify if patients are already presenting with so much frustration and they're like, look, I just want all the workup. I understand it could be painful, but I want it done. Then we'll go for it, as opposed to some patient who says, look, I'm already in so much pain. I really want to avoid that if I can. And then also using, statistics in terms of, well, patients with Hunter's lesions tend to be our older patients too. So we can probably spare the younger patients from the get-go, because we know it's not necessary. It's really more of a clinical diagnosis, exclude other potential etiologies, particularly infection, and then based on symptoms, we can diagnose them.
Okay.
But certainly if someone isn't getting better and you really think they have IC, personally, I also don't really like to do cysto in the office for patients who have IC, because I just think it's mean. They're already having pain, and I think it's really difficult for them to tolerate. So we just kind of presume they have IC, and we'll schedule them for cystoscopy, possible bladder biopsy, possible injection of steroid into ulcers, possible hydrodistension, for all of those, just so it's diagnostic. And then if they're already asleep, potentially also therapeutic for them. But yeah, it's not required for the diagnosis, but people who you really have a high suspicion or have IC and are just not getting better, those are the ones who you really need to make sure they don't have ulcers, because those, you usually have to do something to them, whether you're fulgurating them and or injecting with steroid. Those don't typically just get better with non-invasive treatments, unfortunately.
Mhm.
I'm getting away from hydrodistension a bit. I just didn't have the best results. I'm interested in what Dr. Scott and Eilber do, if they're still, if they're doing hydrodistension, or how you have it in your armamentarium.
This is a dumb answer, but when it works, it works. If it doesn't, it doesn't.
Right.
So, I think that if
Yeah,
you're taking a patient for cysto under anesthesia, you try it. I have patients who, and the theory, I'm sure Marty, is you're causing a temporary nerve damage, right? So you're kind of breaking that pain cycle ideally. And I have patients who, when it works, like it's almost around the clock, like every 6 months, because that's probably when the nerves kind of regenerate and they want their hydrostension. But I have some people who are like, it did nothing. So, I mean, it sounds like a dumb answer, but when it works, it does. If it doesn't, it doesn't. But I do think it's worth trying when nothing else has really helped.
That's like the same philosophy for all of IC treatments.
So, I mean, you can apply to a lot of different disease states, I mean.
Yeah, but no, it's really true with IC. It's so individualized,
So since there aren't a lot of conventional medications, like as we all know, Almiron has not been the best for the eyes, so causing retinal maculopathy. So a lot of doctors aren't prescribing it anymore. And then I believe it can't. Is it safer if they do it through installation? If they do the Almiron installations as opposed to the oral? Yeah.
Yeah, interesting. The bladder lining is supposed to be impermeable. It's probably a little defective in IC. That's why people have the symptoms.
Yeah.
But you really don't, or you shouldn't absorb much systemically when you put it in the bladder. And I don't even remember who, but years ago I was listening to a talk on IC and someone said, oh yeah, they put the Almiron in their installation. And, over the years, it's always been our to-do list to actually study, but I don't know, Dr. if we still do, but we used to put Elmer on all our installations, and I swear when I started using it in installations, the patients had better responses to the installation. So I am a believer in it. Do I have science to support it? No, but
okay.
And just to add on the, I have a lot of patients because I practice where Dr. Lowell Parsons, who actually was sort of the developer of Almiron, where his practice was. And so patients, there are those patients that have been on it a long time and swear by it. And so I think it's important to know that the risk of Almiron is much later after being on it for like 15 years. So I won't stop patients on it. I'll just make sure they get their eyes checked, and have a retinal exam once they've been on the drug for like 10 years or so. So I think that's, again, patients who've been on it, they had a response. I think the safety profile, I think is obviously we want to be, whenever there's an FDA warning, we want to do the right thing. But the recommendation is really that, if they get their eyes checked and also just keep in mind how long they've been on it, I think that can also help. But yeah, I was in practice with Dr. Eilber for a while. And we did that same, I did the crushing the Almiron, and it seemed to be a nice installation cocktail.
Yeah, I hear a lot of people are now trying to avoid taking it orally and, doing it with if they're combining it with, DMSO or whatnot, directly into the bladder. Yeah. So why don't you tell me a little bit about, so now that, we don't have a lot of conventional medications, like I said, for IC. So what supplements do you think are best for the condition?
Well, we're going to say the supplement that we helped develop, of course, but that's also based on, I think, a lot of things that we heard our patients say over the years, and also the data that is available for certain supplements, and also things that honestly make sense. I don't think many people would disagree anymore that it's a defect in your GAG or glycosaminoglycan layer in the bladder. So things like hyaluronic acid or N-glycosaminoglycan building blocks, if you will, should be helpful with that. And things that we know that are naturally soothing, like aloe, quercetin, which is a natural anti-inflammatory. Interestingly, when I was a resident about 1 million years ago, they were using quercetin even in transplant patients to help to decrease some of that rejection. So that's why we heard over the years patients saying, I use, acid blockers, I use aloe, I use this and that. And people were taking so many things, which is why don't we just put everything together that
Mhm.
we know helps, just to make it easier for people. And, because for me, whether it is my beauty routine, my health routine, whatever it is, like, why do we like Target? Because you can do everything there, right? So that's why I like to have a supplement with everything in it. Just makes it a lot easier for you to take.
Mhm. So tell me a little bit about your supplement.
We really used our, like Dr. Eilber mentioned, our clinical knowledge as well as what's in the research. So the clinical knowledge in terms of what patients anecdotally have said works for them, and then also just the issues we see them suffer with. So we saw, again, to address all those patients who are coming in with recurrent UTIs. Maybe they have UTIs, maybe they've just been on tons of antibiotics for because they were diagnosed with UTIs instead of IC. We know that their microbiome is altered significantly. And so we start, like with our supplement, we like to start with a kind of UTI defense mechanism. So D-mannose, probiotics, and this really just helps with a little bit of UTI prevention. And then a daily maintenance, helping to rebuild that gag layer as well as anti-inflammatory. So the glycosaminoglycan, or the glycosamine, the hyaluronic acid, ashwagandha helps with kind of more of the systemic stress, and then the aloe vera. And then as a third kind of component to our IC system is more, well, let's help you try to get back into eating some of those things that may cause a flare. So the calcium glycerophosphate, as well as the sodium bicarbonate, which will help kind of alkalinize the urine and hopefully help you tolerate more of the things that you enjoy.
Mhm. Okay.
But it's just really, the approach is just at what people experience, right? You need something on a daily basis to maintain you, and you need something for your flares. And for a lot of women, because they've had so many antibiotics because of presumed UTI, that's why, like, you had this initial kind of reset. So there's like this. I love what we did with this company. It's like 1, 2, 3. So you know what? Reset, help get your kind of microbiome back, if you will. Start your daily maintenance, which, I had an issue years and years ago where, unfortunately, I'm sorry, I love my hair, but it was falling out, and like I had bald spots, and it was probably a combination of stress and some other things. And my dermatologist recommended some supplements, and, nothing is going to come back overnight, but thank goodness it finally did. And I think an important thing, whether it's the supplement we're talking about or anything else, it's a matter of using it long term. Like, no supplement, like no vitamin is going to work overnight. And
Mhm.
frankly, I got back to where I was with my hair. Like, I'm not stopping it. So I think that once people kind of get to where they are, also it's human nature that when you are better, you stop what you're doing. But I think it's also important that if you feel good, it's probably a good idea not to stop. It's kind of like how people always say, like, oh, I don't really have any medical issues. Oh, but you take high blood pressure medication. Yeah, but it's controlled. Okay, but you still have the issue. Like, even if your IC is controlled, you still have the IC. And although, we would love to have that temptation of having our chocolate mousse and washing it out with a red wine, probably still a bad idea, regardless of, what you're taking.
Mhm. I agree. I I
In
always say,
addition,
yeah, no, I was just gonna say, when, people are like, "Oh, are you cured?" I don't ever use the word cured. I'll just say, I'm in a good
Controlled.
period, or
Yeah.
I'm in remission, or those words. I never like to say cured, because I think once you have an icy bladder, you're kind of stuck with
It's
it.
a chronic condition. It is a
Yeah,
chronic condition.
it
And you may
is.
be fortunate to not have symptoms or have it controlled for a while, but yeah, I have a lot of patients who fortunately do well for a period of time, but then they kind of forget and go back, and then they have a huge flare, and it's really hard to reset once you trigger everything again. That's why, like, there is something to that saying, an ounce of prevention is worth a pound of cure.
Yeah. And I think stress is, for
Ugh,
most people, the biggest,
for
because,
anything,
yeah,
stress is bad for
ev-
everything.
yeah, stress is a killer. It is just yeah. And I think managing, and I really help people to try to focus on stress management, because I think it's definitely number one for,
And we
it's,
recognize that, which is why ashwagandha also went inside the supplement. Look,
which, yes.
is there as good of data on all the supplements? You could say, is there as good of data on, like, Elmeron for that? But, you
Mhm.
know, there are a lot of things we don't understand, but we know consistently that they help. So like ashwagandha has been around for, decades, if
Mhm.
not centuries. And, before we had modern day medicine, this is all people had to rely on, things like aloe vera, so
Yeah.
you can't deny those things. And, again, being in practice for a long time, I encourage people to try whatever they want to, because the reality is, whether it's your health, your money, nobody is invested as you are. So I'm just here to tell you, yeah, you know what, that's okay, but don't do this because it's dangerous. Or, if you take too much of this, it could be a problem. So, I think it's also very important, and Mari, I'm sure you've experienced this. You have to find someone who is treating your condition, who is willing to work with you and, keep you safe and be open-minded. So if someone is really militant about, the way you're being treated, and you don't feel comfortable discussing, it's probably not the best fit for you.
Mhm. Mhm. No, it's good that, and I think it's great that you are all open to, supplements, right? Because sometimes in conventional medicine, you are more interested sometimes in pushing the prescription drugs. And this is, people can access these supplements very easily. They're all safe. And that's so I think it's great that, people are starting to understand the benefits of some of these, like you said, supplements that have been around for centuries.
Well, the same kind of questionnaire that we did for some of these IC things, 40% of people with IC use supplements.
Yeah.
So they are either looking for something other than going to the doctor, or in addition to what they're getting isn't working, because almost half the people who have IC are using supplements, which is why we also had to wake up and say, hey, if we really want to help our patients, we probably should look into how we can with supplements, because the majority of our patients are using these and we don't even know what they're using.
That's great. Yeah. I've been on amitriptyline for too many years. That's another thing. Like, it's sometimes, being on a drug like amitriptyline, could maybe mess up the cognitive functioning over long-term use, right? So I'm always like, okay, I'm going to get off. I've been on it for over 20 years. And
Yeah,
so
but the trade-off is you're functioning on a regular basis that
Totally.
way normally. So I don't
it's
know.
been
so
so
hard.
helpful for my sleep. So I just,
Yeah.
didn't want to give it up.
I wouldn't stop. I wouldn't stop
What
if I was you.
what dose do you take, if I may ask?
What else do I take? I take magnesium.
Oh yeah, what the dose of
Oh.
Advil? Yeah.
10. I was on
Well, it's so
35 for a
small.
really
It's
long
so
time.
it's so
And
small, honestly.
it's small. I was on 35 and then I went down to 10.
But
And
people
I'm
take it
finding
for a
10
long
is,
time for depression. The doses are much higher, so that's why I didn't
yes.
even.
Yeah.
I'm sure you're fine.
Well, and honestly, for IC, I'll usually start at 25, and if they can tolerate it, even go up to 50.
Mhm.
So usually higher doses are often needed for pain. So if you're on that low of a dose, that seems very safe from like a long term like memory standpoint. I think 10 is probably not too harmful.
Yeah, that's what they say. So
That's the hard
okay,
thing
I
is
won't
like
feel that guilty then.
we are they, Marnie.
but that's the hard thing. It's like, because as we get through, in the menopausal time, like I'm like always looking for the best sleep regimen that doesn't like impact my memory, because that's really important now. And so it's really hard. And we don't have a lot of consensus out there on what's safe, what's not. It's hard to like. And then again, as we're talking about women's pelvic health, I was at this with a group of kind of moms that are different ages, 40s, 50s. And they're like, well, what hormone regimen should I be on? My OBGYN doesn't want to put me on estrogen. And it's really hard. I mean, we talk about this all the time. It's like, why are women being denied estrogen? And there's a lot of misinformation around it. And it's hard because when doctors
but if you don't give estrogen, what are they going to give? That's like the most deficient hormone.
Exactly. But it's even like I'm always like we me and like Victoria and Karyn, I'm often like asking each other, well, and that's where I've learned. Karyn's a certified menopause. What is it called, Karyn?
Well, now it's the Menopause Society. They changed the name from NAMS, but yeah, I'm a certified menopause practitioner. Because the reason I did that is by nature of what we do, because we do a lot of pelvic health, which of course are women of perimenopause and menopause age. And I had so many women who were fine. Someone said, oh, you've been on your hormones too long or something else, which is no science behind that. And then they're not fine. I'm like, so you really just need your hormones back is what you need. And, we do testosterone management in men all the time. But, you just want to also just get the certification just so that you're up to date with everything. And I think, Dr. Scott, didn't you get yours recently, or you're going to?
I'm taking my test next week.
Yeah.
Ooh, I love it.
But also just to clarify, the discussions that Dr. Anger and I have really don't apply to Dr. Scott because she's actually much younger than the two of us. So let's just put it out there.
I'm approaching perimenopause, okay?
Yeah. In 10 more years, maybe.
It's
I can start early.
I know.
Yeah.
But she just had a baby a couple years ago, so I doubt she's.
Yeah, I know. She's.
Yeah. But nowadays, women are having babies late, and then they're going basically from being postpartum right into peri.
Yeah.
Yes. I personally, I think that prolonged nursing brings on perimenopause because you suppress your hormone levels. That's why, because you had to have been somewhat like not perimenopause if you got pregnant on your own, and then all of a sudden, like your perimenopause or menopause, I do think, just suppressing all those hormones probably accelerates what would naturally happen. That's, again, no science, my personal beliefs.
Well, but the symptoms of like vaginal dryness are definitely correlated with breastfeeding. And no one, we don't learn that like very commonly.
No, it's just supposed to be all beautiful, right? And like the best experience. It's like, no, can we just tell women what really happens? Because they're still going to breastfeed, but at least they won't feel like they're alone and they're the only ones who's experiencing it.
Well, this is why we actually wrote a book. We didn't bring this up, but we actually, just spending hours and hours and hours seeing so many women for all these pelvic health conditions, so scared, so embarrassed, so ashamed, so feeling so alone. It was just heartbreaking. So we wrote this book, A Woman's Guide to Her Pelvic Floor, What the F is Going On Down There, to try to help make it interesting with a little bit of humor because we're urologists, so we can talk about issues.
I'll put the link so that people can
wonderful
under the and then along with your supplements, the Femetry supplements as well.
Yeah, it's an easy read and just helps women feel much better because I think probably just like I'm sure you experienced with your IC, you felt alone, you're the only one. Same thing with these women who are having all these problems after pregnancy and breastfeeding, and all they see is on TV, all the celebrities having this great experience and everyone's talking about how great it is. And she's like, wait a minute, am I the only one who's wetting my pants? Am I the only one who has pain with intercourse? No, you're not. And this is what happens. And that's why I can't tell you how many times women have come to our office and cry out of relief simply by us just telling her it's normal.
Mm-hmm.
Absolutely.
One thing I had happen recently, it made me kind of sad. I had this woman who was actually doing like Karyn's patient, doing great on hormones for like 10 years. And then one doctor took her off. Then she went to another doctor. She ended up going to 3 doctors who gave her not only 3 different opinions, but 3 different like strong opinions. Like, no, you need to go off that. That doctor was wrong. Oh, you should go on this. And so finally, I just called like one of the doctors and like came up with a plan. But it made me sad that this poor patient, like, it's not her fault that the doctors don't have consensus or even know what they're doing, or they're going off label and doing all these things. Like, I feel really badly. It just seemed like really, it shouldn't be so hard to get.
Yes.
We need a much more efficient system, and we need education at a young age, right? Like, why is sex education not including information about perimenopause?
So that's our next project. We're going to write a book for college age girls and their pelvic health.
Thank you.
Did you know what your birth control options were in college? Did you know what you should and shouldn't be doing? Did you know? Yeah. I mean, these are things that I always like to say we get one health class in junior high and that's it. Yep. The rest you're on your own, or if you're lucky, your mom might tell you something, or your girlfriends might actually know what they're talking about. But otherwise, you're left to your own devices.
Unreal.
Yeah. And it's funny because one of my daughters doesn't talk to me about a lot, but when it comes to this, it's like, because she's actually so desperate to know some answers that she actually talked to me about stuff, which makes me sad because most moms don't have sort of the same like background that we do where we can like help them,
But your daughter will only talk to you about her vagina. That's it.
Right. Exactly.
Wow. Well, no, that's one thing I'd like to eventually get into is getting, pelvic health education into schools, because I think it's so important.
Mm-hmm.
And even kids.
Good luck with that.
Yeah, I know. I, I think Canada's even worse than the States. So
No. From what I
no.
understand, Canada is probably one of the more liberal ones because they
Mhm.
actually have sex education, I think, at least, well, because we've had a lot of fellows from whatever reason from Canada. And from what I listened to them, there is definitely more than what they're getting here. That's for sure.
Mhm. Mhm. But we're
Which, if
also
you don't think it's good, then it's probably just bad all over, but at least you're getting more there.
Europe, places like France, they're doing. I mean, they have, you get a pelvic PT come to your
The
house.
French are always that way.
I mean,
The
they're
French are
so
always ahead.
yeah. It's just like kudos to them, right? And why can't we be there too? So hopefully we'll get there. But anyways, I would love to just say thank you so much for
Thank
coming on. This
you.
has been really great. We explored some really, we went all over the place, which is great. And there's a little bit of something for everyone in here. So I will, like I said, I'm going to post the links so that people can access the Femetry supplements. And then I'll also post your book as well, which sounds really great. I'm actually in the process of reading it right now. And it's really wonderful. So
yeah, let us know, Marnie. I mean, there are so few people like you who are out there promoting pelvic health and are, I don't want to use this in a negative way, but are legit about it. And, so if you need any help, you want us to write a blog for anything, we are so, as you can tell, we're really passionate about educating women and everything. So yeah, let us know. We love to partner with people who have a platform to bring this message and, that it is important to deliver accurate information.
Absolutely.